In this third podcast on the urinary system, I'd like to talk about the microanatomy of the kidney. We will trace for you a little bit later the pathways of the renal artery, the interlobar artery, and the arcuate artery. We'll talk about the interlobular artery. We've already mentioned a little bit about the major and minor calyx, and you know about the ureter from your anatomy. What we can first say is that the kidneys have a connective tissue capsule that covers the surface. This connective tissue capsule moves inward at the hilus and covers the renal sinuses, the walls of the renal calyces, and the renal pelvis. And any of the surfaces in these regions that are in contact with urine are covered with a transitional epithelium. You already appreciate that the kidneys can be subdivided into a cortex and a medulla. So the cortex very characteristically can be identified because of the renal corpuscles, and the medulla very characteristically because of just the profiles of the various tubules. We've talked about medullary rays as cortical structures that consist of the straight portions of the proximal and distal tubule and collecting duct. We talk about these as medullary rays, even though they're cortical structures that are projecting or pointing towards the medulla. We've already mentioned for you cortical or short-looped nephrons and juxtamedullary or long-looped nephrons. A little bit about the development of the kidney. This will remind you of what you had, I think, in the first week of medical school. The kidney arises from intermediate mesoderm during the 4th week of fetal life. There's the mesonephros, and in the 5th week of fetal life there's the metanephros. And by 34 weeks there's approximately 1 million nephrons per kidney, and from the point of view of development, the kidney is a classical case of reciprocal induction, where nephrons and collecting ducts have different embryologic origins. In the adult kidney, one collecting duct will drain many nephrons. The collecting ducts arise from the ureteric bud, which is mesonephric mesenchyme, and the nephrons arise from the metanephrogenic mesenchyme. This cartoon that came from Dr. Sadler's textbook just reminds you of the development of the kidney. You can see metanephric tissue caps and the collecting tubule, and the diagram is kind of just highlighting this reciprocal induction. And interestingly, the nephron is developing from a distal towards a proximal direction. Nephrons are coming from the metanephrogenic mesenchyme, and the collecting ducts are coming from the mesonephric mesenchyme. And by the end of the 5th week of fetal life, you actually have structures that look like this, where you've actually had a glomerular capillary bed invading this primitive Bowman's capsule. This is more complicated than you need to know for our course, but I just want you to remember it because you may see some shelf exam or board questions to relate to this. There's a transcription factor called WT1 that's expressed by the metanephric mesenchyme, and this allows tissues to respond to induction by the ureteric bud. Glial-derived neurotrophic factor and hepatocyte growth factor are produced by the metanephric mesenchyme, and these act through specific tyrosine kinase receptors to stimulate growth of the ureteric bud. Fibroblast growth factor 2 and bone morphogenetic protein 7 stimulate mesenchyme and maintain expression of WT1. There are additional gene products like PAX2 and Wnt4 that are produced by the ureteric bud. This allows the metanephric mesenchyme to actually differentiate into the proximal and distal tubules. Now, again, I'm not going to hold you responsible for these different transcription factors here, but something that you should keep in mind. Wilms tumor is a common tumor that arises in children from cells in the kidney, and it is when these transcription factors and the intracellular communication between the metanephric and mesonephrogenic mesenchyme go astray. You can get Wilms tumor. So you may see something about these transcription factors in your reading later in your clinical training. As we've said, the uriniferous tubule consists of the collecting duct and the nephron, and the physiologic differences in the cells located along the pathway of the uriniferous tubule may very well correlate to their different embryologic origins. The first thing I would like to consider is you should be able to relate or correlate what you see in a histological section to what you might think of as the structure of the kidney. For example, if you were to take a cross section like this, you'd see profiles of tubes. If you were to take a cross section like this, you might see profiles of tubes. So here you'd see profiles of two thin tubes, thin limbs of Henle's loop, and a large collecting duct. If you took a cross section like this, you might see a profile of a thin limb, a thick limb, and a collecting duct. So you've got to be able to first correlate what you see histologically with where you are in the kidney. So for example, here is a histological profile where I see sections of vasa recta, like so, at these thick arrowheads, and sections of collecting ducts, like so. You also need to keep in mind the concept of a renal pyramid in relation to the medullary rays. And I can roughly define for you a renal pyramid as a structure that has its base along the boundary of the cortex and medulla, like so, with the apex roughly like so, pointing into the deep part of the medulla. Here's another way to look at this diagram. What I've shaded in green is the renal pyramid, and what I've shaded in yellow is a medullary ray, which is going to be roughly a renal lobule. If you'll allow me to continue, I hope this will become clear. Here are renal corpuscles, so we know we're in the cortex, and here are these medullary rays, these structures that contain the straight portions of proximal, distal tubules and collecting ducts. So here's a medullary ray, here's a medullary ray, here's another bit of medullary ray, and another bit like this. This is another way to look at these structures. Here would be an arcuate artery, like so. The arcuate artery gives rise to interlobular arteries, so traced like that and like that. And from the interlobular arteries, you have afferent arterioles, which are going to ramify into the glomerular capillaries and then give rise to the efferent arterioles. So if I go over to the diagram on the right, here you might imagine here's a glomerulus, here's a glomerulus, another glomerulus. So you might imagine an interlobular artery like so. By the way, this interlobular artery is also called a cortical radial artery, but this interlobular artery giving rise to an afferent arteriole. And then here are the medullary rays. On the diagram here, the interlobular artery, the glomerular capillary beds, another interlobular artery, glomerular capillary beds, a medullary ray. And the artist has just shown here some straight portions of kidney tubules. So they've shown just straight portions of the nephron. So now let me come back to this cartoon. You've got arcuate artery giving rise to interlobular artery or cortical radial artery, giving rise to afferent arteriole, the glomerulus giving rise to efferent arteriole giving rise to the capillary beds surrounding this portion of the nephron. So peritubular capillaries around the cortical nephron, vasa recta around juxtamedullary nephrons. So we can say the arcuate artery gives rise to the interlobular or cortical radial artery. The cortical radial artery gives rise to the afferent arteriole. The afferent arteriole gives rise to the glomerular capillaries. The glomerular capillaries give rise to the efferent arteriole. The efferent arteriole gives rise to the peritubular capillaries or the vasa recta. Now, you'll recall in an earlier podcast I said this arrangement of the blood vessels, the efferent arteriole giving rise to the peritubular capillaries or the vasa recta, can have some significant clinical implications. Can you imagine what might happen if glomerular capillaries are damaged or if blood flow is inhibited through the glomerular capillaries? If that's the case, you could basically pinch off blood flow to the peritubular capillaries or the vasa recta. And if you do that, you can basically be damaging the nephron, because you're going to be cutting off the blood supply and obviously the oxygen and nutrient supply to the distal portions of the nephron. Here is another way to look at the microanatomy of the kidney. I've got a renal artery coming in, giving rise to segmental arteries. The segmental arteries giving rise to the lobar and interlobar arteries. These are big arteries in the medulla that are defining a boundary of a renal lobe. And I'd like you to remember that the medullary portion of the renal lobe is equivalent to a renal pyramid. The interlobar artery giving rise to the arcuate artery at the junction of the cortex and medulla. The arcuate artery, as we've already described, giving rise to the interlobular artery, and then the afferent and efferent arterioles. So if I take this part of the diagram and expand it like this, the way these yellow lines are going, I'm defining a renal pyramid as roughly the portion of a renal lobe that's in the medulla, defined by the lobar and interlobar arteries, and then the cortical structures, these renal lobules, the renal lobules with medullary rays. And you can imagine a renal lobule, and I've drawn this here. I've had to separate them, but the medullary ray would contain the straight portion of the collecting duct and the straight portions of the proximal and distal tubule. If you were to combine those, these would be the medullary rays. And we can think about the medullary rays as being at the axis of a renal lobule. So here we show the medullary ray at the axis, and the boundaries of a renal lobule could be defined by these interlobular or cortical radial arteries. So I think you can appreciate that these arteries giving rise to the glomeruli giving rise to the efferent arteriole, but also you're going to have the collecting components of the nephron in this medullary ray. So this whole structure we can call a lobe. So you've got the renal pyramid as the medullary component of the lobe, and these various renal lobules as the cortical components of the lobe. Now, in a human adult, lobes are not usually apparent. If you see them, they're an anatomical variant. In the human fetus, lobes are readily apparent. This just reviews what I've just told you. Here is a lobule. The boundaries of lobules would be these interlobular arteries, and the axis, the central axis of a lobule, would be these medullary rays. So the medullary ray is the central axis, and the interlobular arteries as the boundaries of a renal lobule. Here are some nice scanning electron micrographs of the renal cortex showing the renal corpuscles, and you can see the interlobular arteries, and you can see structures that would be either afferent or efferent arterioles. And just a higher power view giving you a sense of the interlobular artery giving rise to the afferent arterioles. So let's just summarize the microanatomy of the kidney. The blood supply in the kidney defines the boundaries. The lobar arteries will define renal pyramids. The arcuate arteries, and by the way, the arcuate veins, will define the boundary between the cortex and medulla. The parenchyma reflects the structure of the nephrons and collecting ducts. Renal corpuscles, the proximal convoluted tubule and the distal convoluted tubule, are in the cortex, and this is sometimes called the cortical labyrinth. And the medullary rays contain portions of the straight segments of proximal tubules, distal tubules, and the collecting ducts. The thin limb of the loop of Henle and the largest collecting ducts, or papillary ducts, sometimes called ducts of Bellini, are considered medullary structures.